Good morning, sir.
Good morning. How are you?
I am fine, sir. We will start in a few minutes, in a few seconds, sir.
Yeah, no problem. Thank you. I'll just try to see if I can share my screen. If that's okay with you.
Yes, sir, you can try. So your screen is clearly visible.
Okay, sounds good. Thank you. And this will be on YouTube, right?
Yes, sir.
Okay.
Shall we start, sir?
Yeah, sure. So you want me to share screen before?
Sorry, sir.
You want me to share screen or you tell me how it goes?
Sorry, sir. I will let you know.
Okay, sounds
I will
good.
let you. So, hello everyone. A very good morning to one and all participants here. I am Shivan Rana, Assistant Professor and Moderator of this event. Firstly, I would like to welcome all the participants and our eminent speaker joined us today on YouTube Live for the International Conference on Recent Advances in Artificial Intelligence, Innovation and Drug Discovery in Pharmaceutical and Life Sciences, organized by Minerva College of Pharmacy, Indore, Himachal Pradesh, in collaboration with Association of Pharmaceutical Teachers of India, APTI, HP branch. So let me give you a brief about our college. Minerva College of Pharmacy had its inception in 2018 under the aegis of Mass Saraswati Education Society with the noble aim of imparting quality pharmacy education to aspiring students of the region. The college is approved by AICTE, PCI New Delhi and is affiliated to HPQME. The aim is to provide the growth and development of pharmacy education in the state of the Himachal Pradesh. So we are organizing this international conference dedicated to highlighting recent scientific and technological innovation that contribute in drug discovery, formulation development, molecular biology, pharmacogenomics, clinical research and life sciences, with a focus on emerging tools, novel therapeutic strategies and integrated approaches. So now let let me introduce you all to our eminent speaker, Dr. Manik Chabra. So Dr. Manik Chabra is from the alumni of ISF College of Pharmacy, Moga. He did his PhD in pharmacology and therapeutics from Max Rady College of Medicine, University of Manitoba, Winnipeg, Canada. Dr. Chabra is an accomplished researcher whose expertise lies in medication safety among vulnerable populations, population-based studies, evidence synthesis, and clinical trial methodology in vulnerable populations, including children and patients with low kidney function. Across his academic and professional journey, Dr. Chabra has held various roles. He worked as a research assistant in the Department of Pharmacy practice at NIPER Mohali, the Child Health Research Institute of Manitoba, and the Clinical Pharmacology Lab at the University of Manitoba. He also served as a research data analyst grade 2 with the kidney dialysis and transplant research team at London Health Sciences Centre, and is currently a post. President of ISPR Student Chapter ISF College of Pharmacy. Among numerous accolades, he has been honored with Dr. Mark Nicholson Entrance Award in Pharmacology and Therapeutics, the Shuley Family Scholarship in Oncology, the FGS Research Completion Award, and the Research Manitoba Doctoral Fellowship Award. He also accounts for Western Doctoral Fellowship Award and the Best Poster Presentation Awards. So I request to our eminent speaker to please share his knowledge with us. Dr. Manik Chabra, sir, please.
Sure. Good morning to one and all present. Thank you, Dr. Shiva. Special thanks to Dr. Kapil for sending this invitation, allowing me to share some knowledge on my expertise. So today I'll be sharing expertise on principles of pharmacoepidemiology and drug safety for beginners. And just before I begin, I'll just give an outline for today's presentation. I'll be talking about what is pharmacoepidemiology and why we study this, then different study designs and how to execute studies. Then I'll talk briefly about case reports, case series, then case control studies, cohort studies, and in between something about cross-sectional studies, then systematic literature reviews, and at last I'll tell about the bias to consider while designing studies. So before I begin, what is pharmacoepidemiology? So it deals with utilization of drugs in a broader set of population. Then it links with influence of those drug utilization on influence on health outcomes, followed by linking them together to study their real world risk and benefit of medications. Now let's talk why pharmacoepi.
Sorry to interrupt, sir. Please, can you please click on the slide show button so we can see it in the full mode, zoom mode. At bottom there is a button.
Actually, I was on slide. Maybe I'll share my screen again.
Your screen is clearly visible, but sir, you have to click on slideshow.
Yeah, my entire screen. I mean, now you should be able to see it. So, are you able to see my full screen now?
Yes, sir. Your full screen is clearly visible, sir. You can.
Okay. Sounds good. Thank you very much for highlighting this. So, I was talking why pharmacoepi. If you see, normally industries, they do industry or whether academic or industrial partners, they conduct clinical trials with strict population, like all of the population have very strict inclusion exclusion criteria. Especially if you see they exclude pregnant breastfeeding women, they exclude children or patients who are very sick. So because of their strict inclusion and exclusion criteria, and then as a result, if you see that drug product is to be used in real world using real scenarios, and in actual, the drug is to be used in the population, which is representing like pregnant, breastfeeding women. If you see children have diverse age group. There are infants, neonates, toddlers, adolescents, teenagers, and then there are women, breastfeeding women, pregnant women, and then there are some elderly patients who are aged above 65, and with increase in age, there is decline in kidney function, there is decline in hepatic clearance of the drug, which further increases the plasma concentration of the drug and lead to various side effects, and this predispose them to risk of adverse events, which we saw during COVID-19 when the vaccine was got they got market approval, but then they weren't studied in real population, and that resulted in increase in side effects and even resulted in mortality in some of the cases. And just before I begin, I'll just tell you how to execute a study. For executing a study, you need a research question, and that research question usually comes up with a PCOS format, and then you select appropriate study. In the field, then further that thing is tested using cross-sectional surveys, followed by single unique case, we call that case reports, then case series, case control studies, quad studies, and R series, which I consider as randomized controlled trials, and they're the gold standard. And then at last, systematic literature reviews and meta-analysis. Now I'll just give you an overview what are case reports. Case report is a detailed report of symptoms, signs, diagnosis, treatment, and follow-up of an individual patient. And then case reports have further sections where you just write patient description, like say a 65-year-old male was presented to emergency department with so and so chief complaints. Then you link patient's case history, his comorbid conditions, whether he was suffering from diabetes or he was suffering from hypertension, then his physical examinations, which includes blood pressure, pulse, and other kind of things, then his pathological tests and other investigations, followed by treatment plan and expected outcome of the treatment plan, followed by actual outcome. And this is normal case report. It can be of any rare findings or any rare intervention which they found. Okay, during COVID-19 people started using different kind of drugs. We saw like someone got cured with ivermectin, and if there is a single report you can publish it, like something miraculous or something very rare, can publish as a single case report. And then more my work is related to drug safety and pharmacoepidemiology, so I'll be talking about more about pharma and all. So if you see case reports related to adverse events, people respond to therapy differently. So in that case, you should have a case history, what kind of patient was at, and then medical history, what kind of medications that patient was taking, especially if you're linking some rare adverse event with that patient. And then temporal relationship, when patient took that drug and by what time patient got those adverse drug event. Like if you see about severe cutaneous adverse drug reactions which are related to skin, those adverse events well within few days, and for some adverse events it takes even a year or sometimes weeks, especially if you see there are some drugs which lead to adverse events like cardiac arrhythmias. And then later on, we determine causality assessment, which is done with different scales available in the market, like WHO causality assessment scale, Randomized scale, then drug D-challenge. D-challenge stands for if someone well adverse event, and then you stop that drug, so it is called as drug D-challenge. And then re-challenge is something. If I say someone was suffering from tuberculosis and he was taking drug XYZ, and then patient developed instantly hepatotoxicity, and then they withdrew that drug from that patient, but later on they found okay, when they analyzed risk-benefit ratio, and they found that if they will stop that drug, patient may have relapse of tuberculosis, and then
then they reintroduced that drug, and that adverse event reappeared. So that's a typical example of re-challenge, then severity of adverse drug reaction. And if you have all of these things, in case of rare findings, especially if you see there is a drug we call as allopurinol that is used for gout, and in patients, some patients who are taking that drug, they suffer from Stevens-Johnson syndrome and toxic epidermal necrolysis. In that case, like if you found someone using that drug or specific drug and found that severe adverse event, and that too it's rare, you can publish it as a case report. And then later on, if you see, you are having now a group of similar cases, and then you want to publish all together. Like, for example, that I gave example of allopurinol and risk of Stevens-Johnson syndrome. You have now 5 consecutive cases. You can publish all 5 of them together, and then we call it as a case series. And if case series, it describes group of patients with particular condition. Can be any diagnostic condition. So case reports, case series can be of any medical condition or rare exposure, providing detailed information about their characteristics, outcomes, and follow-up. Then further, this is followed by a specific strict inclusion criteria, and then we should follow a precise definition what that specific condition is. You need to define that prior, and or what that specific exposure rate is, and then all the cases should be consecutive. It should adhere to that specific definition which you are linking. And then there are some certain sampling techniques which we say for the case series are based on either disease or exposure. Exposure can be any medical device, it can be any drug, or can be even any herbal thing, and based on specific conditions. Then later on, you select certain variable of interest. You are selecting drug A, B, C, and then if you want to link it with certain adverse event which patients taking that drug are experiencing, then you can select that specific adverse event as variable of interest. Then detailed section and clear definition of predictive variable of interest are necessary. For example, patient was taking any other drug, and then their test results, any pathological results, so someone is suffering from arrhythmia because of any drug, so you need all detailed examination of their ECG or any cardiac Doppler or any other stuff, and their intervention, complications, adverse events, and outcomes. Then this is followed by systematic collection of data and robust analysis, which further shows the quality of case series studies. And then here is a typical example. Someone published a case series where they found that particular drug was linked to Parkinsonism, and then they published all the cases together as case series, and that can be done even in your regular practice, in a busy pharmacy, or you're working as a clinical pharmacist in a hospital. And now I'll talk about cross-sectional studies. Now, again, that same thing is, as I gave example of allopurinol. Now, that same thing comes to particular hospital setting. Someone who is working in a busy OPD or orthopedic OPD, and you're getting a lot of patients who are suffering from gout, and they're taking allopurinol. And just you want to see how many patients are suffering from Stevens-Johnson syndrome while they were taking allopurinol or they were suffering from gout. And you just doing one-time survey. This cross-sectional studies are kind of survey, and you can find out a measure which we call as prevalence. And then primary objective is to provide snapshot or cross-section of the population at particular moment. And then another example I would give, for example, you guys have 30 students in Bachelor of Pharmacy, and out of those 30 students, you just want to see when students got admitted during year 1, what was their BMI? Like, you want to see how many students were obese. At that time, you will do a survey and you just calculate their weight, height, and you will calculate the BMI, and then you say, okay, 5 students are obese, 5 out of 30, and you can find out their prevalence, like 5 are obese. But later on, if I get If I say, okay, students got into Bachelor of Pharmacy program and I want to see how many were obese on day one and how many were obese when they graduated. So in that case, we will use certainly other designs, which I will walk you through in coming slides. But now you guys might be wondering, what is prevalence? So prevalence, it's very simple. Let's see. The proportion of individuals in a population who have a specific characteristics or a condition at a particular point in a time or over a specified period. For this, if you see formula to calculate this is total population of a specific subgroup divided by number of existing cases into 100. And now if you see, if a health survey finds that 50% of population has diabetes and the prevalence of diabetes in that population is 15, which means 15 out of every 100 individuals have diabetes at time of the survey. And same thing if you want to see a group of population who are taking specific drug and you want to see whether that specific adverse event exists in that population. So you will just survey them and you will see how many patients are there in total and how many had adverse event. That way you can find out prevalence. And then everything comes with limitations. So what are limitations of cross-section studies? If you see in cross-section studies, you cannot determine temporal relationship. So temporal stands for time. Since data collection is at single point, like I gave you an example of class of 30 students at the day one of their Bachelor of Pharmacy days, you just surveyed at the specific day one, just for day one. You don't know what kind of factors or what kind of things played in when they were in their, I would say when they were there in their class 11 or 12. So based on that, you cannot see, based on single time point, you cannot determine cause and effect relationship, what exactly made them obese, or determine the temporal sequence of events can be challenging. And then, so this is something prevalence and incidence. Prevalence is something which is prevailing in that area and incidence is number of new cases. So cross-section studies provide prevalence data but do not provide incidence. Efforts like in India, we have pharmacovigilance program and recently there was the pharmacovigilance week also, and we can contribute to national and international efforts. Then further these things or these publications play a key role in knowledge dissemination and then help to keep medical and scientific communities informed about safety concerns associated with these medications in the post-marketing phase when drug comes to market after clinical trials. And then, if you see right now in the center, you guys are now standing in the present. I'm covering next study designs. Just before that, I'll give you a quick shot. You are in the present, and if you go to past, this is something you're studying something retrospectively. We call this as retrospective design. And next is from present to future. We call this as prospective design. And in terms of exposure now, I'm now talking about case control study. If see in case control study, you have outcome in the present, and then you go back and see using retrospective data whether those exposures were linked to outcomes, and then in prospective design, case control, we look at exposures again in the present, and you follow up those patients for outcomes based on which we define case and control. I'll cover this in coming slides. So this is what we call like cohort studies. Now this is typical example. So in cross-sectional studies, I'm now comparing three of things together. In cross-sectional studies, individuals are examined at single time point, just like I gave example of BPharm students. You did interview or survey on day 1 and see how many were obese. This was one thing. Then in case control studies, you look at the particular outcome and then you go back and see whether there were any factors which were present. Just I would say doing a lot of eating junk food or lack of physical activities lead to obesity in those kids. We will go back and then see if you have any data collected for those risk factors, and then you can link, okay, patients who are in BPharm, you can take them as cases, and patients who are in diploma in pharmacy, you can take them as control and see whether particularly which population was linked with more those factors, and then you can link, okay, that the specific thing is related, is increasing risk of obesity in those youngsters. And this design is known as case control design, and then I have a beautiful example in coming slides to elaborating more with some hands-on experiences. Then in cohort study, you like individuals are exposed to particular factor, and then you look for outcomes, whether those outcomes are present or absent. Then you have population who is exposed to that specific drug. In my slides, I'm talking about pharmacoepidemiology, drug safety, and it's all about medications. So someone who is exposed to medications, then look for outcomes in cohort studies, and then individuals who are not exposed, but again you are looking for outcomes. Now here is the example. So you are living in particular district, you can say district in Himachal Pradesh, that we have whole population, and now you are following that whole population. Out of that population, you will select cases. So here in your example also, this is called Minerva College of Pharmacy, and then you have cases with outcomes. Kids who are in bachelor pharmacy, and then you can say controls who are in diploma in pharmacy, and then you follow up them, and then you look for exposure and non-exposure. Like you have specific prior factors. You can say, okay, lack of physical activity, lack of proper consultation, or like eating a lot of junk food can predispose them or can dispose them to risk of developing obesity. So you just follow them. Then in control, again same thing. People who are without outcome, and then you are looking, okay, whether they have those factors, and then you do some kind of analysis, which I call incidence. This is something new. So I have formula for this. So for this, again, this is a retrospective design. We are going from present to past. And then strengths for this, there are few ethical concerns, especially I have example in coming slides. You cannot control an experimental study, and you can say, okay, someone, you want to see carcinogenic effects of smoking. Smoking can cause lung cancer, and you cannot say someone to, okay, you will put them in experimental group. Someone who is smoking, and you can say, okay, you smoke 2 cigarettes every day, and I will follow up you for 10, 20 years or 5 years. You cannot do that. That is very unethical, and this is quite not feasible with experimental studies. But with observational design, especially, you can do a case control study, and you can see someone who is smoking cigarette daily. You can follow up that, ask that person, can you share some risk factors? There are those limitations, like there are some biases. That person won't be able to recall whether what was his lifestyle 5 years back. We can't even recall like what food I had last week, right? So there are some biases which I will talk in coming slides too by the end. Then This requires less money, fewer subjects are needed to make association, no need to wait for long latency diseases to develop, especially for the latency is something. If I'm taking a drug, and now I'm talking about drug. I took a drug and I got side effect after I would say 6 months. Maybe I'm just talking about oral anti-hyperglycemic agents which are used for management of diabetes. So in that case, there was a time period when I started taking that drug, which I'll call it as okay, in that state, and then it takes time for that drug to show its effect in our body. So I can say after 4 weeks, that effect kicked in. So the time period when we took the drug and when symptoms started appearing, we call it as latent period. And that again is same thing if we talk about someone who got exposed to COVID-19 and he developed symptoms after 14 days. That 14 days is latent period for disease, and similarly that thing I gave you example is latent period for any drug to show its side effects. Then it is easy to explore effect of many exposures on an outcome with case control design, and it is not possible with cohort design. Then it is used for diseases with little information, so which means you can study multiple risk factors at one time. And it is important for infectious disease outbreaks, especially during COVID-19. The case control study would be the best one if you want to study different outbreak investigations. What are initially we didn't knew COVID-19 was spread from bats. So you want to trace the source. What exactly is causing COVID-19? So you can trace based on what were the different risk factors, and then at last you can say, okay, using different statistical techniques, you can say this particular risk factor is associated, and then you can draw a conclusion that bats were causing COVID-19. And then limitations. So limited to study single outcome. We can study multiple outcomes. We cannot study single outcome in this design. Not good for rare exposures, because for rare exposures, for this cross-sectional case control studies, you need a lot of good sample size. But in case of rare exposures, sample size is less. You won't be able to, the population is rare, so it is not good for rare exposures. Then there is risk of systematic bias, which we call it as recall bias. As I gave you an example, someone who is smoking a cigar and he cannot tell about his lifestyle 5 years back, and he cannot determine whether his lifestyle caused him lung cancer or because of smoking. Then maybe I'm sure about time sequence, when he started smoking, how many cigarettes he smoked, that we call as exposure. And then when that specific disease kicked in, that's another thing. And then there are certain measures which we use in this pharmacoepidemiological study designs. We see ratio of event in one group to risk in another group, which is often used to assess association between exposure and outcome. And then we call it as risk ratio. For example, I'm comparing two different drugs, drug A versus drug B, and I found 5 people in drug A, there were 100 people who were taking drug A, they developed, out of 100, 5 developed adverse event. So I'll calculate risk in those 100 people in drug A, and similarly I will calculate risk in 100 people who were taking drug B, and out of that, only I'll say 3 developed an adverse event, and then I will calculate their risk, and then later on I will divide them and I will get a ratio. So we call it as risk ratio, and in drug safety studies we evaluate these things using relative risk. And then I'll talk about now odds ratio, which is particular estimate in case control studies, and the later one, the before one was relative risk. It is used in most of the cohort studies as an effect estimate, where we determine whether the specific adverse event was associated with specific drug, or I can say the other way, that this drug was associated with this adverse event based on the effect estimates. And and I will make you calculate that in coming slides. So, an odds ratio is ratio of odds of an event, odds of developing any disease in one group to odds in another group, commonly used in case control studies. In odds ratio, you calculate odds of exposure in control divided by odds of exposure in cases. So let's talk about risk ratio, and this is again a hypothetical example. We have data of like 6 with 6 zeros, so 60 lakh people in the source population. You can say 60 million people in the source population. We compute the probability of disease in both exposed and non-exposed group because we have the denominators for both exposed and unexposed. As I told you, risk, I will calculate risk. So this is a table. We call this table as 2 by 2 table, where we have exposure on one side and then we have responses, like kind of binary. It has binary responses. Binary means 2, either yes or no. And same thing goes for outcome. It has again binary responses, yes or no. So someone who got exposed to smoking, I say yes, and then they develop their outcome. So 700 people out of 1 million developed lung cancer. And then people who were not smoking, I found that 600 out of, like, I would say 15,000, they developed outcome. So for this, I'm like calculating risk in exposed divided by risk in unexposed. And then if you see all together, smoking was causing 5.83 times risk of developing lung cancer. And these things are made these things very simple so that you guys can understand well. But when it comes to designing studies, it doesn't mean like, okay, out of 1,000 people, there are some factors which can confound or which can bias, which can cause errors in these results. Like, if I see out of this 1 million people, some people are doing alcohol, some people are having some pre-existing lung disease, or some people are having some genetic mutations. We usually have them in a model and then we control them. Now, for case control, for cohort studies, now if you see there is exposed group, someone who is taking drug. Now we are following those patients and we will see whether they develop conversion. Here is the example of allopurinol, which is used for gout. And those patients, and then we'll see how many patients in allopurinol group, they develop Stevens-Johnson syndrome, which is like skin reaction, so simple skin reaction or adverse drug reaction. And we call them as smear cutaneous adverse drug reaction. So people who were taking allopurinol, we were followed for 5 years, and after 5 years, who developed outcomes, who developed those skin reactions, and who developed those skin reactions, we have as yes and no. And then how many patients who were unexposed, and then they were again followed up, and then how many developed outcomes, and how many who didn't develop outcomes. So unexposed can be either any, so again, you can't take healthy volunteers in unexposed, you need to take someone of similar disease condition, which means you are comparing someone with someone. The lay example is say someone who is really doing good, there is a verb and we say like, see that Sharmaji compared to say like he's doing so good. But that doesn't mean like your parents are comparing you with him. If he is doing good, that doesn't mean like you and he have same resources. Similarly, if you are comparing allopurinol population, it should be someone with gout who are taking another drug. So it should be very comparable. That means like you are comparing apples with apples in terms of the exposure, in terms of disease condition, and then you follow up for 5 years and see who the outcome and who didn't develop outcome. So in this case, we calculate odds ratio. Again, that I won't go again for this table. You see, it has exposure, outcome, and then for odds ratio, it's a simple formula. You multiply 48 with 750, then 2 with divided by 2 with 250, and we get 72. So now here in this case, and if I just have very fragmented form, so also having a disease of smoking among those with lung cancer, history of smoking with lung cancer divided by no history of smoking with lung cancer, which is 48 by 2. And then same thing you are doing is you are having no, so also having history of smoking among those without lung cancer, which is equivalent to history of smoking without lung cancer divided by no history of smoking without lung cancer, 250 divided by 750. And then later on you are dividing 48 by 2 and then all divided by 50 divided by 750. And now here it is, you are having 72 odds of developing lung cancer if you do smoking. And then if you see strength of cohort studies have to study multiple outcomes at the same time. And it was different for cohort, for case control study. What case control studies were doing, they were studying one specific outcome and multiple risk factors. But in case of cohort studies, they have to study multiple outcomes in same exposure. Well, like they want someone who is taking allopurinol, you want to study adverse drug reactions related to skin, you want to study adverse drug reactions related to cardiovascular system. So this cohort study is the best design. Then if exposure is rare, cohort design is efficient, method to study relation between exposures and outcomes. Then if you see, most of the cohort studies are retrospective in nature, which I explained in the last slide, that you are going from present to past. You have exposure and then you will define an outcome, which is relatively inexpensive. You are just using retrospective data with prospective cohort. Study, again, prospective study is expensive to do. So retrospective design is best when you have lack of funding, which we call as funding constraints. Then since at time of entry in the cohort, individuals do not have outcome, the temporal between exposure and outcome is well defined. So I say someone who is taking drugs, I gave you example of allopurinol, and I'm following them for 5 years. So I have exact temporal relationship, which I have other than established when I was doing cross-sectional surveys. And then again, they do have some limitations. One major limitation of prospective cohort design is that it is time consuming and costly. I'm talking about prospective, not retrospective again. And for example, if you want to study incidence of cardiovascular disease in patients with psoriasis, so you want to see how many patients who were suffering from psoriasis, they have cardiovascular diseases, and you will follow up them for many years, and it takes a lot of time, a lot of resources. And then later on, if you see in retrospective designs, the exposure and outcome variables are collected before study is initiated. So can result in lack of measurement, lack of other requirements, and some exposures may have been assessed differently. For example, I want to study how many patients were dispensed with allopurinol and how many developed acute cutaneous adverse drug reaction. But I'm saying dispensed, but there again, it makes a difference. I'm not sure if patients were dispensed with allopurinol, how many were actually taking those allopurinol. So it is very, very difficult to quantify exposure. And now comes randomized controlled trials. They are considered very gold standard. So if I had an interactive session, I would always ask this question. Why randomized controlled trials are considered as gold standard? And if anyone is interested, they can type in chat. I can't see chat though, but I would answer this question on everyone's behalf then. So in randomized trials, they uniformly randomize patients in intervention and control group, and that leads to random distribution of confounding variables. Now, as I told you, I was about to talk, okay, if there are 30 students in class, you want to see how many will get the B's from year 1 till year 4 of their Bachelor of Pharmacy. What I will do is, if I just randomly allocate, you come in control, you come in case, and then I'll follow up them, and then we come in control and we come in intervention, and I'll follow up them for 4 years, and I'll see how many were adverse event, or that how many had increase in BMI. But again, someone who is already obese, they will try to come in one group, and some who are okay, they are very fit, they come in another group. Just like how we select different teams. If you are having cohort of 20 people, you want to play basketball, you want 10 people in one team. So there are chances that captains will just cherry pick only players who are good, and at last all that players they end up in one team. So that same thing goes with the drugs and patient population. Someone who wants to study the fact that there are some variables which may influence that outcome. We call them as confounders, and that can be more in one group and can be less in another group. That may confound the results. But in case of randomized trials, you do randomization. And now, if I just want both the teams to have equal number of good players, what I will do is I will give them a point. I'll say, okay, toss. Then that toss will give 50% probability that good player can go either in team 1 or team B or team 2. So those players are uniformly distributed in both the groups. And then the main reason, as I told, like why we call randomized trials. So first thing is randomization. Then we have control group. Then blinding, which prevents detection bias. Like someone who is suffering from diabetes, and if they get to know they are getting oral hypoglycemic agents and like anti-diabetic drugs, they will think, okay, no, I need to outperform, I need to have good proper blood sugar control. They will stop eating sugar, they will start physical exercise. That can impact the outcome at last, like you are getting blood glucose levels. That patient will have glucose levels normal. We cannot decide whether that glucose levels were normal because the patient was taking that drug, or patient got extra cautious. Oh, we know maybe something is like wrong with something. So that's the reason they blind that. They don't let the patient know who is getting drug and who is getting control group, or who is getting placebo, which is no drug. And then they see whether there is any difference between drug group and control group. Then we have four outcome measures, which is again done. I'll talk about the biosystem measures. Like, for example, someone wants to study effect of antihypertensive drugs on blood pressure reduction. Someone who is taking, I would say, amlodipine. They are measuring BP using normal sphygmomanometer in one side, and in another side they are measuring using electronic monitor, and then it is calibrated. So, but in case of trials, they have very uniform outcomes at measures, so that everything is proper systematized. Then we calculate power, especially power is done to capture rare adverse events or rare efficacy outcomes. Then randomize patient, and then even people who randomize, only that person knows. Neither treating physicians, nursing, that we call as blinding. So putting that they send serial envelope a day before, so that even pharmacist who is dispensing drug doesn't know which person is to receive intervention drug or which person has to receive placebo or control group. And then lastly, systematic reviews. Systematic review is a comprehensive and structured synthesis of existing finding with specific research question or topic to follow the rigorous and predefined methods to identify, flag, aggregate, and analyze relevant studies. Now, for this, I usually give example of, now we recently had floods in North India, and now there is flood. It increases risk of water-borne infections, and now we are uncertain whether being a pharmacist, your doctor asks you, okay, hey, can I give drug A, B, C so that I can do prophylaxis for diarrhea in flood areas? And then someone comes, some of your colleagues says, no, drug B is more effective. So what you will do is you will undertake a systematic literature review, and you will see how many patients, and you will collect all the randomized trials or observation studies, and you will see how many patients suffer from diarrhea who are taking drug A, and how many patients suffer from diarrhea who are taking drug B, and both the drugs were used in flood settings for prophylaxis, for to prevent diarrhea cases. And then for that, like you are collecting all the, you will collect, first you will identify all the studies, then you will select which study to include, then you will see their methods, whether those studies are good. It's not like garbage in and garbage out. You have to take only three or what exactly has, like, there are no biases or there are no errors, then analyze relevant studies, and then you will come to a conclusion. Okay, taking drug A is beneficial, that okay, then you publish that report. That report goes to whole scientific community, doctors, and maybe that report can even change the policy. They can use that drug whenever there is any flood in that specific country or region. And then primary goal is to provide unbiased, as I told you, transparent summary of available evidence, so that you can inform the decision making in healthcare. It can be used for policy or other fields. And then why I call it systematic reviews. Why systematic reviews on the top of hierarchy, which I explained during my initial slides. You see, they are very comprehensive, synthesize all evidence on that specific topic. They are very transparent and reproducible. So they follow predefined protocols. We register them with protocol registries like Prospero or Open Science Framework, OSF, and they follow proper methods, Cochrane and the Prisma guidelines to report those results. Then we minimize bias with structured search, study selection, and data extraction. Then we do evidence integration by combining findings from diverse study designs, which I spoke about in my during the last slides. Then we identify research gap, highlight area for the needed investigations, and then later on that specific report which is made by the systematic review is used for decision making. It is used either to develop clinical guidelines, or it can be used to develop policy. You can inform policy and clinical practice, and then if you do quantitative synthesis, which is meta-analysis, where you do all the results, that helps to improve the precision of estimates, which we call, for meta-analysis, we call as Cohort power. Now I have one exercise for you guys. So suppose we follow 1,000 patients for year 1, and by end of year, 50 patients who are in diabetes. What would, and this is like we are following 1,000 patients who are taking drug XYZ, and you want to see whether that drug leads to diabetes or not. So you saw that 50 were diabetes, and then what way you would calculate? I gave you typical examples of incidence, prevalence, risk ratios, odds ratios. So what would be your answer? You can type in the chat online. So what would be your mail? So how you will calculate that? So that you can quantify and you can tell that specific drug is actually. I'll repeat again. Suppose we follow 1,000 patients who are taking drug A for year 1. By end of year, 50 develop diabetes. And what way would you calculate to describe this risk? So, you can't see the chair though, but I'll show my cards now. So, we calculate cumulative incidence. You see 50 out of 1,000 diabetes, which is 5% in 1 year of taking that drug. And then if 5% is developing, you may say clinicians, okay, patients who are already obese and who are at risk of diabetes, please use this drug with cautious. If they will take this drug for a year, there are chances that they are at risk of developing diabetes. This is something we can weigh with drug safety studies. Then now follow up their time base. Now imagine everyone is followed for a year, and that was the situation. This particular situation was like, okay, someone you followed, but in reality, if you just see your class of B Pharm students, everyone did that of pharmacy or undergrad degree. Suppose you were 50 students when you started your program, and when you guys graduate from that program, you are only left with 45. That's the real world, like 5 patients or 5 students drop from their class, and you end up with 45. So now in this scenario, imagine someone dropped after 6 months and some stayed longer. What would you wear now? So in this case, it is very simple. So 50 cases, so total follow-up will take person a year. This is something which needs consideration. 50 cases, I'd say it is 6.25, and when I was calculating this, it was 5%. So there is even more risk when we are considering that thing in account. And then if you see, we call this as cumulative incidence, which I spoke right now. Before this example, so for cumulative, it is simple. You are dividing total number of cases divided by population at risk at start, which is 5% in year 1. But this is something has to be calculated in actual. Most of the people, they do error, they do mistakes, they do calculate cumulative incidence, but that has false estimates. Those results are false. In reality, incident rates will be calculated, which has percent time equivalent as percent time incidence. We will see rate of all cases, but unit of percent time at risk, then account for varying follow-up time. So incident rate is equal to new cases of that specific disease with that drug divided by total percent time at risk, which is calculated by subtracting patients whom we lost. So there were 1,000 people, some dropped out, total follow-up patients were 800 and 200 dropped out, so you have at last 800, and now you're calculating 50 divided by 800, so this incidence comes to be 6.25. So there is huge difference between incidence of 6.25 and 5 when you do larger studies. This is a small example. So we need to consider this incident rate in account while we are doing any kind of pharmacoepidemiological studies. Now I'll talk about biases. Bias is something error, bias is confounding. So here is the example: someone who is taking paracetamol for fever, and someone who is very late, they report that paracetamol is causing fever. That is not actually true. We call it as confounding by indication. The fever wasn't because of paracetamol, or paracetamol was taken for that thing into account. And then if you put into FIRS, FIRS stands for FDA Adverse Reporting System. And in FIRS, we see a lot of confounding by indication examples are there. And for example, seizures are commonly reported with FDA. If you drop in that database, that is a really confounding by indication. Then this occurs when exposure and outcomes are both related to a third factor. So they have something in common where we can have confounding bias. It even can be confounding by disease severity. So you want to conduct a study and you want to see patients who develop, renal failure in diabetes. So you are following a patient. Someone came to clinic, you started following up that patient. He developed renal failure in 6 months. And someone who newly developed diabetes, and that person developed renal failure after 5 years. But there are even other considerations to play. So again, the person who came at first was involved with severe disease condition. So we call it as confounding by disease severity. So these things you need to consider while designing your pharmacological studies. Here is another example: patients who are on statins. We take statins to reduce blood lipids, blood cholesterol levels, and then statins have low mortality. Patients who take statins have low mortality. But that doesn't mean that statin is resulting in low mortality. Can be patients who are taking statins, they got more aware. Someone who is very health conscious, they say, oh, doctor prescribed me statins, I should exercise more, I should adopt to more healthy styles, I should eat salad instead of my dinner. And that makes your results confounded. So this is typical example, like patient who are taking statins, they will have low death rate. So you need to consider their lifestyle, other things as confounding variables, and you need to adjust for them. And then second thing is selection bias. This arises from non-random inclusion and exclusion of participants. For example, you just selected healthy users instead of diseased individuals, which means you want to see, you have one side, you have normal burger bun, normal which comes from normal market, and another side you are comparing it with McDonald's burger bun, and McDonald's burger bun, you will see which one gets more fungus, and you will see that normal bun gets fungus within 2 days, and then McDonald's burger bun is not getting fungus at all. Then why we do this about that? That's why I give this example. But that doesn't mean like both the buns have similar material, similar kind of things. So you never compare these individuals with healthy individuals. Then there is depletion of susceptibles. For example, I am studying effect of antipsychotic drugs, and I'm just seeing which drug has more risk of suicides, and I'm following up them for like 5 years or 10 years, comparing two different antipsychotics. But people who are taking antipsychotics who are very sick, they will then go wrong. They will not, if they are very sick, they will not come to my clinic. They may go to higher tertiary teaching care center or very good hospital, and next time I will lose them. So this is another thing which we call as selection bias. We need to select very carefully, loss to follow up. Sometimes someone immigrates from Himachal to Haryana or to Punjab, and next time you won't get to see that patient while you are doing any study. So that is another thing. And especially in case of hypertension, you sometimes lose to follow up, like you are not able to follow up with that patient, especially with antihypertensive studies, because who cares, like someone is having high BP, symptoms doesn't even originate for 5-10 years, and they don't bother to take drugs because of lack of awareness. So you need to select carefully that if you are considering anyone to participate in your study, that person has to be detained as long as study is to be finished. Then information or measurement bias, misclassification of exposure or outcome. You are misclassifying your exposure. For example, you are classifying exposure based on drugs given by pharmacists, but you actually don't know whether the patient you treated, and you define exposure based on drug dispensing. Did that patient really take that drug or not? This is another thing you need to consider. And these all things are to be incorporated in your study designs so that you can minimize bias or error. Then prescription records, again, it's not in actual medication use. Again, what is in records, it doesn't mean actual and real word. Then outcome coding errors. Now another example, patient take drugs but get their prescription filled, which means they get their drug from pharmacy, but do they really take that drug? Then we have channeling bias. So certain drugs are prescribed to sick patients. If I talk about rheumatoid arthritis, someone is suffering from knee pain and all, it's an autoimmune disorder, and then we see new biologics. They are very expensive, and those drugs are reserved only to patients who are very sick. And now you are comparing new biologics with patients who are on methotrexate, or I would say hydroxychloroquine, who just diagnosed with rheumatoid arthritis. So this can cause channeling bias. You need to consider this. And then the last one is immortal time bias. You are now following someone incorrectly to the treatment group. Like you are considering, I'm not talking about person years, which I gave an example. You are considering that latent period or lag phase also, the phase before which time period between taking that drug and appearing symptoms, and then that leads to immortal time bias. And then in another example, like in a core study of HRT, we call as hormonal replacement therapy and survival. So you are seeing whether hormonal replacement therapy patient can survive for long term. And then patient, in order to assess its effect, patient must survive long enough but patients who are on hormonal replacement therapy, they die early, and you call this as in-motor time bias. You need to consider this while designing your studies. And then with this, I summarize my session. Thank you everyone for your patient listening. I'm happy to take up any questions, or I can request facilitator to open up questions from chat, as I can't see the chat box.
Thank you, sir. It was a very great speech. So, there are some questions from students' side which are watching you online. And first question, I think they have doubt about the retrospective study and prospective study. So, can you please explain it again?
Yeah, sure. So I'll share my slide for that. That will give a better description about retrospective and prospective design. Sorry. So, in case just now you are standing in the middle of this slide, like in the present, in the middle, in the present, and now you are looking from present to past, or whether it's outcome or risk factors. So we call it from present to past. So this is retrospective design. And if you want to look from present to future, we call it as prospective design. So this is like simple. From if you're going from present to past, that date, it's retrospective. If you are interviewing someone who got admitted from year 1, and then you want to follow up them until they graduate, that is prospective design. Or if you want to see students who are already in year 4 and you want to see what kind of lifestyle they had, now you're going from front to back during their year 1, that you call it as retrospective design. I hope that makes sense.
Thank you, sir, for the clarification. So, next question I have is about the risk ratio. So, you have talked about the risk ratio. So, on which basis the calculation is made? I mean, is it based on the retrospective study or it is based on the prospective study? So, can you please clarify?
Yeah, okay, that's good. A good question. So, we can calculate risk ratios for both retrospective and prospective studies, and most of the cohort studies calculate risk ratios. And if I just talk about like estimates in cross-section study, they calculate odds ratio, and in prospective study, cohort studies, they calculate risk ratio. And then risk ratio is calculated based on like risk of that specific event in that population who is exposed to drug, and risk of that event in population who is not exposed to drug. Then we divide both the risks as ratios, and then we calculate that risk ratio. And if risk ratio comes to be 2, we say patients who are exposed to risk who are exposed to that specific drug, they have twice the risk of developing adverse event compared to the unexposed population.
Okay, so thank you so much for your clarifications. I think that's all from student side, and I have only 2 questions from their side. So, thank you so much for your great speech, sir. The whole session was very informative. You have shared in details about clinical trials, adverse events, study design, and risk factor, and many more. It must have imparted a lot of knowledge in the mind of students and participants who are watching you online. So I think this is the end of the session. Again, sir, thank you so much for being a part of this event. But before that, I want to 1 minute, sir. So this is a gesture of appreciation. So please accept this online. Sir, you are for being a great speaker on this event.
Sure, thank you very much. It's my pleasure to sensitize you guys and share some knowledge.
So this is the end. So thank you so much, sir. Again, I'm thanking you for being a part of this event. So
Thank you.
okay, sir. Okay.
Yeah, pleasure is mine. Okay. Thank you.